if I now formally welcome Helen to our meeting. Helen, welcome. Thank you for joining us.
Thank you, Rafi.
Uh, uh, I know you are giving us a short talk on management issues and physician associate involvement. And then we have some kind of questions for you and we can have a dialogue.
Great, Rafi. Thank you very much.
Thank you.
So I'll just bring up a set of slides. Just give me 1 second. I've shared these already with Karen and they're very welcome to be shared. And I think she's also recording the session so that others can watch it, which is fine with me. Doesn't look like it's come up for you. Is it coming up now? It's just loading up. Just give me 1 second. So let me just introduce myself first of all. Helen Crimlisk. I'm a consultant adult psychiatrist in Sheffield Health and Social Care Trust. I'm also Deputy Medical Director there. My background is in education and undergraduate education in particular, and following on from that I've moved into a position of leadership with the college, the Associate Registrar for Leadership and Management. Took that up 3 years ago now, I think it is, 2.5 years ago. So most of it's been through the pandemic with all the challenges that we've all lived through. I took it up not quite knowing what it was, as is often the case with these things, and felt that the right place to start was probably conversations with people and the development of a strategy of the meeting that we were having to try and think what on earth are we trying to do. So I'm going to talk to you a little bit about the strategy in a second, and then I'm going to, which may be a useful model for you to think about your own strategies, I don't know, and then give you some highlights of some of the things that we've done over the last 2.5 years. This doesn't encompass all of the work that the committee has done, but I think it's some of the highlights. And I'll lead into the interest that we have in workforce and my other strand of work, which is as college lead for physician associates, and move on to that afterwards. I'm going to race through these because I want to give plenty of time for discussion. There are hyperlinks on all of these or many of these slides, so if you want to know more about them, there's lots more information there to be had. This was the plan that we came up with. So I want to start by saying this was a co-produced plan. I'm a very strong believer in co-production involving our users and carers in decision making, and we invited the college leads from the patient group and the carers group, Simon and Rachel, to come and join us for this session. And in fact, they've recently been back to help us review it. And their contributions were really useful. They think about things that we don't think about. They put things in a different way. They challenged us in a way which was really helpful. The structure of the strategy was, and I'm really not expecting you to read all of this, it's all on the college website if you want to look in more detail, but I did just want to outline the format that we took. So we started from the point of view of what the presidential leads are, because my involvement sort of is coterminous essentially with Adrian's term as presidents. So we took his presidential priorities as a sort of starting point for all of this and wanted to map our strategy onto that. We spent quite a long time thinking about how to encapsulate our aim in a single sentence, easier said than done, but that's the sentence we came up with. And as you'll see, there's a strong focus on outcomes for people with mental illness there, prompted by our carer and service user leads. We then looked at the college values: courage, innovation, respect, collaboration, learning and excellent, which spell out the word CIRCLE, an initiative that Kate developed a couple of years back, and then tried to map on what people's passions were, what people wanted to work on, because not everybody wants to work on everything, of course, and some of the strands of work which are already ongoing, and map those onto those particular areas. Now, I haven't got a diagram, I'm just sort of devising it at the moment to sort of look at the year one review of that to say where have we made progress, where haven't we made progress, and what else do we want to focus on. But I would point out to you that most of the things I'm going to talk to you about now map onto this strategy in some way or other. Sorry, this slide has come out a little bit strange with the hyperlink not quite right, but these are some of the things that I'll focus on what we've been doing. Obviously, one of the main roles of the Leadership Management Committee is to promote leadership development in all its forms. And there are a number of ways in which we've been doing that, either directly or indirectly by working alongside others. So the Leadership Management Fellows Scheme, which is a scheme for trainees, I'm going to talk about in a minute. There's been heavy support of that. And associated with that, the development of a network of leaders and particularly leadership educators. We want people who can lead, and we want people who can bring that across and help others to develop their own skills in an educational forum. We're lucky enough to have the leader Startwell on our committee, Sahana, and we've been working in collaboration with her. We've also had a session along with Jan Bertel, who is the college coaching and mentoring lead, who talks very much about leadership being supported through coaching and mentoring at all points of a doctor's career in a range of different formats. Some people think that coaching and mentoring is for doctors in difficulty, and it can be very useful for that, of course, but it can also be a developmental opportunity for thinking about how you're going to operate in a new role, in a new position, in a new year. I took up a period of coaching as about 3 months into the pandemic, feeling a little bit overwhelmed about how I was going to operate and do the jobs that I do under the circumstances, which was incredibly helpful. There are lots of ways of getting free coaching. That was a free coaching session offered through NHSEI, but there are all sorts of offers available for that. And of course, you can pay for it yourself if you want. We spent a lot of time working with SAS doctors, particularly on looking at their access to leadership opportunities. They're very keen to have leadership programs. The college may be able to do something of that, but the college is never going to provide leadership courses for everybody in the same way as the fellows scheme, but we've got some conversations going on about what we can do there. And of course, SAS doctors are a much more disparate group or heterogeneous group compared to trainees, with some at the very early stages in their career and some incredibly experienced SAS doctors at later points in their career. The specialty grade, which has recently come through, gives us a new opportunity to think about leadership, particularly if that subgroup of SAS doctors who are at the higher end and in sorry, that should say specialist, not specialty. My apologies, the terminology is a bit confusing. Specialist grade, the new specialist grade that there is there. We've been working with colleagues, including Sabode and people from Calc around the curriculum, thinking about how that needs to develop with the new curriculum this year. And there's a big emphasis on leadership development and trying to think about how we can make that more accessible for trainees. I'm going to talk about the FLM commitment in a second, so I won't mention that now. In terms of consultants and SAS doctors and trainees, we've got a website on the Leadership Management Committee which offers some signposting to leadership development opportunities, and we've also run sessions at faculty, division and international congress level. The College Engagement Network is a sort of spin-off, if you like, from the Leadership Management Committee. Not quite, but I think of it in that way. I'm going to talk about that in a second. And we also engage with the Policy and Public Affairs Committee, and I've already mentioned the coaching and wellbeing leads that we've been involved with. So the Leadership Management Fellowship scheme is in its third year at the moment. It wasn't something I put together. It was put together by the combination of the Leadership Management Committee and the previous chair and the PTC, led by Alex Till in particular. Of course, in the middle of its first year, it ran into the challenge of having to move onto a virtual platform. And that is how it has been pretty much for the last 2 years. We're hoping it's going to be hybrid next year in the way that we're all thinking about how to do things differently. It's a 1 year and it's in programme, so trainees use their CPD time. With 30 trainees from across the whole of the UK. The funding comes from individual trusts, it's £2,000 per trainee. We've got good representation. It's a lot of money, but we've not had any difficulty in filling the spaces for the 30 or so that we have got. I think medical directors and DMEs see the opportunities of training and keeping their best trainees by giving them this opportunity. We changed the structure of it earlier in the year, appointing Alex Till as the director. He was then a higher trainee, he's now a new consultant, with Ross Runciman and Sahana Ahmed taking on the roles of tutors. The programme involves is organised according to the Faculty of Medical Leadership and Management standards, and we're in the process of getting it accredited by the FMLM, which will give the trainees a formally accredited qualification. There's a focus on the FLM standards I've outlined there. They talk about, your relatively simple structure for thinking about leadership in different areas: self, team player, organizational responsibility, and systems leadership. So there's a developmental approach to them, but I do always point out to even our most junior trainees that they can't exempt themselves from system leadership, because we are all tied into systems, whether it be the college or HEE or the ICS or whatever else. We are influenced by these things, and we need to be thinking about what that is, how to operate in those fora as well. We talk about horizontal and vertical learning, and what that really means is a theory and practice. So you learn some theory around leadership development, but that doesn't make you a leader. You then need to do some transformational work in terms to develop yourself as a leader, and that means going out there into your day-to-day work and taking on projects, thinking about being braver, thinking about standing up and taking on leadership roles. The College Engagement Network I mentioned earlier on, this is an initiative started by Adrian and Trudy. The attempt here is to engage more with trusts, to have a two-way conversation or conduit through which we can, first of all, support consultants who are involved in particularly some of the newer transformational work around the long-term plan, because this is difficult work and people sometimes feel a little alone in that, but also get information back from those people about how that is landing in their different areas that we can then feed back through the Policy and Public Affairs Committee and other routes, so that we are getting some feedback mechanism about how this is going on. Because it's focused on the long-term plan, it's England orientated rather than UK orientated. It was initially started out as a pilot with just 12 areas, but now it's England wide. And so all medical directors of mental health trusts have been asked to nominate members to join the committee, and the regional groups have as well. So I say two-way process. It's very important that we've got Linda Gask involved in this as well, because the focus of transformation we're looking at the moment is the community mental health framework, and that is, of course, around greater integration with primary care. So Linda's been a great benefit to the group. We meet monthly or 6 weekly, sometimes with a presentation, sometimes with an action learning set type of way to try and support one another in the areas that we're trying to work on. Move on to the next one. Just to remind you, the Community Mental Health Framework, the college has produced 8 key messages, which we were involved in doing to try and help people understand what is a pretty complex transformational programme. I'm not going to go into that in detail. And one of the things that's come out of this is the necessity for to have a think again about consultant job plans. And we've been working with colleagues in the college to produce some guidance around job planning for particularly community consultant psychiatrists. And when I say community, I mean a fairly loose definition of that, because of course, although I'm focused particularly on the adult community impact, this actually impacts on a whole age range, from children up to older adults. And it also involves colleagues who are working in more specialist areas who operate in a community orientated way, whether that be eating disorders, maternal mental health, rehab psychiatry, etc. So this is cross-cutting in terms of age and subspecialty. A lot of detail on that slide. I'm not going to go through it in detail, but just to say, watch this space. You're going to be getting a draft copy of it very soon as it goes out to consultation, and we're hoping to get some feedback on it. But basically, it's going to talk about the need for system leadership skills and for job plan time to do the non-patient facing work, which is necessary to engage with the wider community that we're trying to engage with in this project, particularly primary care and the developing voluntary sector community, who are also going to be commissioned to develop a lot of this work. Next phase I'm going to talk about a little bit. We spent quite a lot of time talking about sustainability and green plans. That was part of the area that people wanted to focus on in our strategy. We've had the chair of the Sustainability Special Interest Group come along and talk to us, and one of the sustainability scholars. Trust green plans were due to be in place by February of this year. So there was a bit of a rush on in many areas to produce a green plan. There are some exemplary ones out there, but there are also some which have been scratched together rather. One of the things that is that the chair of the Sustainability group, Jacob, was highlighting, and Desal as well, is that there is a tendency for these things to be thought about in terms of estates. You know, we need more recycling, we need better transport, we need, better heating systems, etc. But actually, the real opportunity here to think about what clinical advantages we can get from thinking about sustainability, which at the end of the day will also benefit our patients, whether it's air pollution, whether it's transport, whether it's access to green spaces, whether it's care pathways and how complex they can sometimes be for patients, and how much more sustainable they would be if they were more if they were less complex. So a whole range of things we can think about. And just a challenge back to all of us that the NHS is leading worldwide with its ambition for net zero. One of the biggest employers in the world is looking at trying to become net zero. That's a remarkable thing. There's a big web page all about how that is working out, but there's some really big changes, and that has had influence in other areas of the world, which is good. But the college is also seen as a leader in the UK of embracing this, and also pointing out the clinical relevance of supporting this. So I'm going to move on a little bit now to workforce, and then talk a bit more about physician associates. I'm trying to draw these things together in a logical way. I hope you're following me a little bit anyway. So the long-term plan, one of the aims of it was parity for mental health, a lot of money coming into mental health. The other big policy change was the people plan, which talks about new roles, development, diversity, inclusivity, and well-being. So those are two really important documents that can help us think about how to take this forward. The shocking facts are that less than 33% of our patients receive an evidence-based treatment for mental health. If you compare that to cancer, it's just appalling, isn't it? So we really need to point that out and advocate for that. That COVID, of course, has increased demand. There has been a recovery fund. There's more money coming in, but it's probably not enough. Some of you will have seen the article in The Guardian a couple of days ago where Adrian James was talking about the anxiety that there is there. The ongoing mortality gap that we have with people with serious mental illness and learning disability dying 20 years younger, and the potential for workforce transformation, which we have to think about. Even if we put out more adverts tomorrow for 50% more consultant psychiatrists, we wouldn't find them. We all know that. There are increased medical schools coming through, placed in medical schools coming through. There's a big emphasis on ensuring that medical students are supported to think about the roles in primary care and mental health in the future, and the college, of course, has been leading on that through its Choose Psychiatry campaign. But we really need to think about who else can be doing some of the work. And there are many new roles within mental health. I've listed a couple of them, but they seem to grow at a regular rate, and it's quite hard to keep up with them. And of course, the community mental health transformation will make use of a number of these roles, particularly within the voluntary sector. And we need to adapt to be able to make use of that and think about how we work alongside those people. But I'm going to focus particularly on physician associates because I think that's most relevant to us as doctors, healthcare professionals with a generalist medical education. They've got a degree already in a science-related subject, the majority of them in biomedical sciences, who then do a 2 years master's level course to bring them into a role as a physician associates. They have to work alongside doctors, providing medical care as part of an integral part of the multidisciplinary team. They're not currently regulated. However, it's absolutely clear they will be regulated by the GMC. So we can expect a very similar type of governance arrangement to us as doctors. But that does mean they can't work independently. So they have to work under supervision of a doctor, and in our context, usually a psychiatrist. It doesn't specify what grade, actually. It should be a senior doctor, but I don't see any reason why it can't be an experienced SAS doctor. And as I say, plans are afoot for regulation. Now, what can they do? Well, there's a long list of what they can do there on the left-hand side. Essentially, they can do whatever you want them to do, so long as you train them and supervise them to do it, with a very, very few exceptions. In other medical specialties, they're being trained up to do small operative things, particular areas of expertise. And really, we can train them to do whatever we want them to do. What they can't do is on the right hand here. They're not allowed to sign prescriptions or order x-rays because they're not regulated. But having said that, they are actually what we call prescription ready. So they understand drugs and they understand how to prescribe, but they're just not allowed to do it. In general practice, they're often writing out the scripts and GPs are countersigning them. Because of legislative issues, they're unable to do seclusion reviews, detain patients, or deliver ECT, and I can't see that changing anytime soon. So importantly, when they're employed, they're not trainees. They're employed on a Gender for Change contract. The principal is a 1-year inceptship programme at Band 6 and then subsequently at Band 7 as substantive employees. They need to have a senior psychiatrist supervisor, but that is not in the same framework as we understand with trainees. They don't need an hour a week protected supervision time, for example. They need a pragmatic approach to supervision, depending on the level of the tasks that you're giving them to do and how they are developing as PAs. Many of them, after they've been in role for a period of time, are simply getting the same level of supervision as any other employee of an organisation within our trust. That's a basic requirement of monthly supervision, which can also be group supervision. It's strongly recommended that they are required to be on the Managed Voluntary Register, which is hosted by the Royal College of Physicians, because that guarantees that they're doing the right sort of things in terms of CPD and being appraised in the right way, so that they're going to have a seamless transition into when they are regulated in a year or so's time. The FPA provides a portfolio and suggestions about how to undertake appraisal and their CPD. At the moment, they have to recertify every 6 years. That means they have to retake their finals exams every 6 years. Just think about doing that. That's a thing. That probably won't happen in the future. Yeah, I can see the shaking of your head there. Yeah, but that's what they have to do at the moment. The likelihood is that we're going to move to an appraisal process, which is going to be robust enough so that won't be necessary in future, but that's not actually in place at the moment. Their CPD looks remarkably like a trainee, though. They're required to do CBDs, mini-KEXs, patient and colleague feedback, and we've added in locally, we've got 10 of them in our trust, that we require them to do a QI project and an assessment of teaching as well, because we want them to be good educators. Let's move on. How to support them educationally. I've emphasised the fact that they're not trainees, but clearly they are new employees. They're relatively junior and they do need support educationally. And we've divided this into a range of different things. This is now my local trust rather than a national project, but it gives you an idea of what they need. They will, of course, get all their trust mandatory training. We've got a med-ed-led one, which sort of overlaps with, which is specific to PAs, but also then overlaps with what trainees get. We've also got ours linked into the local acute and primary care PAs, so they can provide education to one another, and then they get their supervision, as I've indicated earlier on. And they need some sort of study budget. Again, that's our local arrangement, but they need some sort of study budget to be able to access some of that training. A lot of this work is brought together in the HE Toolkit, which we wrote a couple of years ago, which tells you, what the models might be, how to go about employing them, a recruitment guide, and some stories from people involved in employing and recruiting PAs. That's recently been updated by my leadership fellow, who I must commend here, Pranav Mahajan, who's done a lot of this work in association with the college, HE and me. This is a summary of some of the work that the college has done. The college received a grant from HEE to progress this work, and this is what we are spending it on, really. The HE Toolkit was one piece of work. There's some networking that goes on. James Compagnon, who leads the project at the college, maintains contact with all PAs in mental health and all of those who are interested in mental health, because, of course, we want to attract those people in as well, and does a newsletter for them every 3 times a year. There's a Twitter account. We're working through a competency framework for PAs in mental health at the moment in association with the University of London, University College London, and that's going to be launched in April. We've run one free CPD conference for PAs. That was right at the beginning of the pandemic and was online, but it was well attended. We had about 150 PAs there, and we're planning our second one, which will be on April the 28th of this year. We've done a seminar to employers, which is on the college website if people are interested, and James can supply all sorts of background information around that, including business plans, if that's helpful. We've got a webinar on the PA site. That's that one I've just mentioned. We're working with the college to produce a membership offer to PAs so that they can actually become members of the college for a sum of money, obviously. And there's a pilot of that going to be running later on in this year. And we've got a promotional film, which I've just shown you the front slide of there, with 4 PAs working across the country, telling you their stories of what they're doing in the area. So I'm going to stop sharing now and open up, and I'm happy to take comments and questions on anything that anybody would like to ask about. How do I share this? I can't quite work out how to get rid of this presentation.
The arrow sign.
Oh, there it is. There it is. Stop presenting. Yep, found it. Thank you.
Helen, thank you. That was a great presentation. Lot of useful information and inspiration. So I will open it to our exec committee if they have any questions, comments.
Perhaps I could put a question for you if there aren't any questions. So do you have any PAs in your area, in your region, or are you aware of any, or who's working on that? But I can see some questions now.
Yeah, Helen, my name is Raj Agrawal. I work for Hertfordshire Partnership Trust, and my colleague, Dr. Georgina Parks, she regularly gets PAs, and sometimes they come for supervision or learning about intellectual disabilities, which is the area we're trying to support them or take interest in, because it's difficult to recruit otherwise. So yeah, Hertfordshire covers 4 trusts, which is Buckinghamshire, Hertfordshire, Norfolk, and Essex. So we have been doing it for the last 2 years, I think. Yeah.
What was the name of the colleague?
Dr. Georgina Parks.
That's interesting. Yeah, I think they are particularly useful in the harder to recruit areas.
Yes.
We've got 2 in LD.
Thank you, Raj. Arif?
Thank you, Helen. I'm a consultant psychiatrist in general psychiatry in Buckinghamshire, part of the Oxford Health Trust. We did a sort of pilot. A trust did a pilot project in terms of doing placements for PAs, which I was one of the supervisors. And I was just wondering, part of the PA recertification is that they require physical health requirements. So if we were to sort of train them in mental health, how will we sort of go around using that in part of the appraisal? So because they do require a lot of physical health, so they are generalists in terms of when you specialize them in mental health, how do we maintain that bit? Do you have any idea?
Yeah, absolutely, Arif. And this is a concern that they have, I have to say. Understandably, they worry about losing skills. They are, the emphasis is on them being generalists. I would put it back to all of us. We all need to be generalists as well. We all need to maintain some generic competencies too. But I take the point that it might be different for physician associates. I think there are 2 answers to that. One is that as the whole physician associate project develops, not just in psychiatry, but across health specialties, there are a lot of them who are becoming super specialised in some very narrow areas. And I wonder whether the idea of them being, maintaining full generic skills can possibly be maintained in the future. There are some of them doing sort of interventional radiology or neonatal something or other. They are becoming super specialist. So I don't think we should be over worried about that. As we train them up, but clearly, it's absolutely essential that they do have some physical health skills, because that's what we want them for in psychiatry anyway, because they bring that expertise in. So the way we've done it locally is to think about, pairing them up with physician associates in primary care, of which there is a massively increasing number growing there. So we've got local arrangements with our CCG, and they arrange things together so that they're training one another, and also with our acute trust as well. So I guess that's one answer to it. And the other thing I would say is that the Faculty of Physician Associates organises a regular conference each year, I think several other sessions as well, where they give regular CPD updates for physician associates to maintain those skills, which is particularly important, of course, at the moment, because they have to do this revalidation exam, so to retake their exam. That is going to go, and I think the emphasis on maintaining all your generic skills is going to be weakened going forward. That's my guess anyway.
Thank you.
Thank you, Deepa. Sorry, I had missed your hand. So over to you, Deepa.
Helen, hello. My name is Deepa Dev, and I work for Surrey and Borders. Helen, I had got up with you about physician associates along with Nat King from East Surrey Hospital earlier before. So I'm a liaison psychiatrist, and we have had some excellent success with PAs in liaison psychiatry, which they enjoy very much because they get the mental health skills working with physical health. My question is about retention, because what has been happening is some of the brighter ones go off and do rather more complicated things. And I think one of the things that prevents us from retaining them is having a substantial cohort, because mental health trusts are so scattered over the county that it is a real challenge to get. So at the moment, we have a couple in liaison. We've just recruited one for home treatment and a couple in old age, but they're all on different sites. So I just wondered if you had any tips about cohesion, retention, things like that.
Yeah, Deepa, I think this is going to be an increasing issue, and at some level we simply have to accept it. These are young people who are going to move. You know, think about what our careers were like earlier on. Of course they're going to want to move around from time to time. So I'm trying to take, I've just had one resign from our trust recently, going to infectious diseases. But, you know, I suppose yeah, a couple of ways of answering that. First of all, yeah, cohesion is really important. So making sure they have time to engage with their professional group, physician associates, either via the college and the faculty of physician associates, or via local arrangements. There's also in some places the concept of PA ambassadors who support groups of PAs to get together. And I think that joint CPD that we were talking about earlier on is another way of helping them feel connected with one another. I do worry about their isolation. I've argued very strongly locally that we should have a minimum of 4 initially, which is what we started out with, and we've now grown with more than that. I think it's also important as you do grow that we think about their representation in wider trust business as well. So we're in the process at the moment of making a business plan for a PA lead, which would come out of the Agenda for Change at 8A. That will be a half-time post for one of our physician associates, and we'll combine it with a tutoring role as well, because we have 40 PA students to look after each year as well. So they will be able to support those students and you know, develop some, you know, a sense of a group and represent that group on wider trust business so that they feel integrated into the organisation. I fear at the moment they often don't, because they're add-ons. They often don't appear in workforce, you know, data. They don't have a professional identity which is recognised, and I think it's our job as doctors to ensure that that is either incorporated within the medical world, to which they are affiliated, or in future, as they develop more, that we encourage them to have their own professional identity and support mechanisms.
Thanks.
Great, thank you. Arif, your hand is still showing. Is it a historical hand or a new one?
Sorry, not taking it off.
Thank you, Helen. So it was a great presentation on kind of the general aspects of kind of your role as associate registrar and also as kind of PA lead for the college. Let me check with colleagues if there are any other questions. If not, then I will open up another discussion. Any comments or questions? Okay, so Helen, we kind of had a membership survey, and it identified a number of strength areas, but it did also throw some challenges towards us. And one of the challenge was how we engage with our membership, and in a way, the first step of it was how we engage and develop our kind of colleagues who are already working with college through executive committees, through faculties. And one very strong suggestion was developing engagement or a leadership program in a mental health policy. And we started dialogue around that, but then as soon as you talk about mental health policy, then the operational framework is systems leadership. I think as you were identifying earlier, and that's a challenge we wanted to tackle. So kind of, so your thoughts, or is there any kind of room for working with you in actually developing a program that we can take to a college through a business plan? That this is what we are going to offer to colleagues who are actually giving their time to college, but hopefully developing a senior engagement workforce actually that can deliver on multiple fronts in future. Any thoughts?
Yeah, Rafa, lots of people are struggling with this at the moment, so you're not the only people to be thinking about that. But that's, I suppose, reassuring that we're all thinking along the same lines. How can we develop and support our psychiatrists, our members, to operate in a world which sometimes feels quite bewildering and changing very fast? And how and you know, with respect, you know, none of us are the youngest of colleagues, and you know, our training was very different. And I ran a session yesterday actually for our educational and clinical supervisors locally in our school to sort of say, you know, I know that you weren't taught about leadership as a junior doctor. I certainly wasn't personally. I don't remember any sessions on that at all. It took me about 20 years to actually feel comfortable with calling myself a leader. The young people are very different. You know, they're being told from medical school onwards that they are leaders, that they need to be leaders, that they will be leaders. And it's up to us as sorry, I'm incorporating you in my cohort here in terms of age, but you know, it is up to us to sort of catch up with some of that and be able to own some of that of that and feel enabled and confident about talking about leadership in whatever form that means. And of course, leadership means very different things depending on where you're sitting as well. But I was prompted to do that by a comment from a colleague who sort of said to a trainee, and it was reported back to me, oh, you need some leadership, do you? In that case, you better go over to Helen and talk to her about it. And I sort of said, no, you know, it's not about pushing it up. It's about us all embracing a concept, you know, and feeling comfortable with talking as ourselves about leaders. In terms of a program, yes, I'm happy to give you, you know, some support with that in terms of, you know, thinking about how to devise a program. Obviously, the fellows scheme has got a particular model at the moment. That's not the only way of doing it. I would point out all of the people who do that volunteer their services and time. And of course, we're very dependent on that voluntary business unless you've got a budget somewhere. And a budget is expensive for, you know, if you want experts to pay experts, you're going to have a lot of money, I'm afraid. We, as I say, in the college have set up a model whereby we, I say we've got Alex and Ross and Sahana leading this, using their special interest time. They don't get any other time to do this, not special interest time, their SPA time to do this. And they have engaged with a range of senior medical managers across the country, including well-known medical directors who you'll know about, Anante, Billy, several others as well. And they come and give their time for a day each year to deliver us one of our sessions. And we model those sessions on the standards of the FMLM. It's not the only way of doing it, Rafael. It's the way we've chosen. There are many ways, of course, of delivering this. I think some of the HEE related programs. I mean, I work with the South Yorkshire and Humber Future Leaders Scheme and have fellows on that programme who are not necessarily trainees because it's a multidisciplinary thing, but quite often trainees. They have a different model. It's an OOPSI, so it's a whole year out. So it's a much more extensive programme than the college is offering. But I think that needs very significant funding behind it. And I don't quite know where they get that from, but I think the Northwest Division HE have also got something running along that lines as well. So there are other models to be looked at. But I rather suspect that, you know, I mean, unless you've got great ways of finding money, that you're going to have to think about what you can deliver yourselves or within your own region. But equally, I'm sure there are many leaders who, given a structure and not given an overwhelming ask, would be prepared to devote, you know, half days or days towards supporting that if there's an underlying structure. So I think structure is your first place to go. Then I think it's also probably important to think about what the needs are, who you're trying to serve. In a way, the college scheme is easy because it's just keen SPRs. So we know where they sit, we know what's behind them, we know where they're going. I think it's going to be harder for our SAS doctors, and that's the conversation we're having at the moment with the SAS Doctor Committee. And if you're opening it up to all doctors within your region, then you've got a very heterogeneous group. Yeah. Having said that, I do think you can work in that way as well. You know, again, our local trust leadership scheme, which I also support, is multidisciplinary and all levels. So everything from support workers up to senior managers. And that's another model for doing things. But I do think you have to think a bit differently about how to deliver under those circumstances.
So if we kind of start a document in progress, so kind of and then I think exchange ideas and kind of consult colleagues. In a way, the core idea is actually a leadership program for kind of us. I'm sure kind of I will have number of learning points and kind of so do other colleagues. And not just for trainees. I think we are essentially talking about more senior kind of workforce. But there is a general view that psychiatrists by training, nobody train us on health policy. Nobody train us on kind of drivers for change. Nobody train us on what is going to come, how to implement. So SEN is an excellent example that college trying to bring people together who are working in different parts of the country and dealing with the transformation agenda. So I think if we start the dialogue, we are having a meeting of division chairs this Friday. I will ask my colleagues, for example, if they will feel comfortable putting some money aside in their business plans, kind of as a startup money for this concept. If they do, then in a way we have a momentum. Of course, if they don't, then we will have to think about something else. And then that will allow us to kind of develop a business plan that we can submit to college. I'm sure I can find, speaking to colleagues, some external kind of route to funding it. If we want to do it well, then of course we need to rely on our own members, but we need to have some speakers from external world as well, so that we have a wider view. Does that sound reasonable?
I think it sounds like a great idea, Rafael. I suspect that so you're right. I mean, so our members will hopefully give their time for free, as we all do in all sorts of ways. External people may need funding. We've chosen in the fellowship scheme not to use external people, but that's because we've got access to experts. We have talked in the past about involving other professions in there, and we probably would have to pay them and/or patient and carer reps who we'd obviously have to pay. But I think probably the biggest financial commitment would be admin, because these schemes, we all come up with great ideas, but unless you've got somebody sitting behind it, making it happen and keeping you to task and organising people and keeping the comms going, then that's where these things struggle, I think. So probably that's what your major cost implication is, I would guess.
Yeah, no, absolutely right.
But very happy, Rafi, to share in more detail than is on the website. I've given you some connections there, but if you need to know any more or want to know any more about the way we have done it, or I've been involved in doing it in different places, I'm happy to share more of that. But also to say, you can't simply translate a program from one place and plonk it in another place. To some degree, they have to be locally developed. You have to do that work around the co-production, around thinking, well, who are we trying to serve? What do we want? What's the time commitment? What's the financial budget, etc., etc. But I think it's a great idea. And as I say, I think particularly we have to think about ways, as you say, of focusing on established consultants, many of whom have got great leadership skills, but don't actually have the language to be able to talk about it as well as they would be able to. And of course, we can all continue to learn.
Yeah, great. Any questions or comments? No. Helen, thank you for giving us your knowledge and your valuable time. Much appreciated. You're most welcome to stay. But if you have other things to do and you wish to move on with your kind of day routine, then we understand how busy you are. But lovely to see you.
Thank you very much for the invite, Rafi. Really appreciate it. If anyone's got any particular individual thoughts, always happy to answer an email, and the presentation's on its way to you.
Thank you.
Thank you.